Immortal time bias is the or error in estimating the association between the exposure and the outcome that result from misclassification or exclusion of the time intervals. If you see the figure, there is an exposure generally, and there is the patient should survive before this exposure. It is called immortal time. Yeah, so this can lead to the bias. So the aim of our study was to estimate the prevalence of immortal time bias in systematic review and meta-analysis, and to assess the degree of which it uh, contributes to the effect size estimates and evidence reversal. So we performed the systematic review with meta-analysis, so somewhat so empirical or exploratory meta-epidemiologic studies. Yeah. So we only included systematic review meta-analysis observational studies, including cohort and case control studies, and included those without meta-analysis or systematic reviews of randomized control trials. So we searched in PubMed, Medline, EMBase, and Cochrane data of systematic review. So two authors independently extracted the data and evaluate the methodological quality. So, okay, sorry. Information on immortal time bias judged and effect sizes with 95% confidence interval for individual studies in forest plot were extracted and to run reanalysis using fixed and random effects method. After extracting data, we evaluate the impact of immortal time bias on the amount of evidence and result and conclusions. First, we calculate the prevalence of immortal time bias by calculating the proportion of studies that involved immortal time bias among all included individual studies. Second, we calculate the discrepancy rate of topics where the result differed in the presence or absence of statistical significance. In the summary, effect size estimates from studies with immortal time bias versus those without immortal time bias. Third, we calculate the proportion of topics where the overall summary result changed from statistically significant to non-statistically significant or vice versa after excluding studies with immortal time bias. So descriptive analysis show the percentage mean with standard deviation or median with interquartile ranges. So we used Meta Package R software and SPSS. So this slide shows the characteristics of included studies. So we included 12 systematic reviews with 25 eligible topics meta-analysis. Only 21 could be divided by immortal time bias, as 4 included only studies without immortal time bias. The median number of studies included for a topic was 6. Among 182 original studies among 25 topics, 44%, 80 studies, were affected by immortal time bias. The most common topics were on oncology, comprising 88%. These are mostly the cancer, various kinds of cancers, but some comparisons were Parkinson's disease, cardiovascular diseases, and orthosis related to allopulmonary use. Most commonly used endpoints were overall survival, and the next cancer-specific survival or progression-free survival and relative risk. Exposures were most commonly described were beta blocker but other drugs, metformin and corticosteroid and statin and aspirin and et al. This slide shows the comparison the result with an immortal time bias. Among the 21 topics, 43%, 9 of the 21, demonstrated concordant results with and without immortal time bias groups. So non-significant in both in 6 studies and significant in both in 3. 57%, 12 of the 21, demonstrated discordant results between immortal time bias groups. In 11 topics, the effect size was statistically significant in the studies with immortal time bias, but not in the studies without immortal time bias. And the opposite was seen in only one topic. So we applied the McNamara matched odds ratio, which showed studies with immortal time bias had 11 times higher odds having statistically significant effect sizes than studies without immortal time bias. This force plot shows the comparison, the result with an immortal time bias. Compared with studies without immortal time bias, those with immortal time bias showed somewhat exaggerated result. This is on the subgroup analysis by immortal time bias for the association between drugs and overall survival. This slide shows the subgroup analysis by immortal time bias for associations between drugs and cancer-specific survival, left side, and risk of disease, right side. So this also shows the similar result. If you see the risk of disease, so the overall result is non-significant, and studies without immortal time bias is non-significant mostly, but the studies with immortal time bias shows the significant result. This slide shows evidence reversal after excluding studies with immortal time bias. So we found evidence reversal occurred in 23.8%, 5 of the 21 after excluding studies with immortal time bias. In all of them, statistical significance was lost after exclusion of the studies with immortal time bias, except one, which had turned from null to statistical significance. So we calculate the ratio of effect size, which means effect size pulled from studies with immortal time bias relative to effect size pulled from studies without immortal time bias, which was 0.71, 95 confidence interval from 0.66 to 0.78, suggesting that effect sizes from studies with immortal time bias was exaggerated by an average of 29% in favor of the intervention and exposure. There are several limitations in our study. First, our sample of 25 topics is not necessarily representative of all topics where from time to event analysis for exposure. So our sample is derived from systematic reviews where the authors were cognizant of immortal time bias and felt they should address it in their work. This may have selected topics where studies with immortal time bias were more frequent, and where the impact of the bias on the overall result was more prominent and thus noticeable. Second, the judgment for each observational study on whether immortal time bias was involved was based on the discretion of the original authors of the systematic reviews. Third, the clinical importance of the difference in the result of studies with and without immortal time bias can be subjective and may vary from one topic to another. In conclusion, nevertheless, we quantitatively captured how far immortal time bias has influenced our knowledge and clinical practice. Given the projected high prevalence and non-trivial influence of immortal time bias, it should be considered to analyze the survivals and improving reporting standards by researchers, as well as collective surveillance from readers, reviewers, and editors were warranted. However, it is unclear how often that might also occur if groups of studies are separated by other characteristics, namely factors other than the presence or absence of immortal time bias. I think based on our observations, I think I recommend to involvement of the statistician, in the early stage of the research will be important in analyzing the observational data. Thank you for your attention.
Thank you. Any questions? I thank you, first of all, for not featuring a paper that actually got mentioned in an annals, in an Academy Award acceptance speech on the lifespan of actors who won Oscars, which is a prime, which was published many years ago, which is a prime example of immortal time bias. But I recommend a 2006 paper, also published in Annals, that explains the problem and reanalyzes it. So if you want a colorful example, that's a very dramatic one. First microphone.
Stephen, JAMA Network. Very nice paper, and as Dr. Goodman pointed out, an illustration of a problem that's been recognized for quite a long time. And that brings me to my question. Did you look at the dates of these analyses, and was there change over time? My impression is that people have become more cognizant of this. They're using new user analyses and target trial emulations and other techniques that ostensibly help to ameliorate the effect of immortal time bias. And so if some of these studies are older, as many of the Cochrane reviews are, perhaps the problem is improving. So I'm just curious.
Yeah. Thank you for your great suggestions. So the studies included in our systematic review, maybe as you mentioned, somewhat old one. So as you mentioned, recent trials include the mitigate the immortal time bias, for example, landmark analysis or time-dependent exposure analysis or others. So it would be great to look at the changes of the inclusion of this kind of method with time trend analysis. Okay, thank you for your great suggestion. Yeah.
Over here.
Markus Krivars, Helsinki, Finland. Thank you. Very nice study. So if I'm understanding this correctly, in order to introduce bias, you would have to have a certain amount of patients who die before they get the treatment. But doesn't it then impact quite a lot on what type of disease you have? I mean, if you go to the hospital and you have breast cancer, it's not likely for you to die in a week or so. It's probably more common that you will live a few months. So how long was the time from, how long was the sort of the bias in terms of time? Because I mean, this must make some sort of difference with regards to the severity of disease. And is it very likely for you to go to the hospital and have cancer and then die in 7 days in order not to be alive in 2 weeks where you get the new treatment or whatever?
Yeah, thank you for your great comment. So because we are included only the published systematic review, so immortal definition of immortal time bias, and so their inclusion criteria in their systematic review varied. So the authors, discretion. So that might be the limitation of our study. So as you mentioned, that might be a very big problem. So several statistical analyses, landmark analysis, that is the reason why recent analyses include those kind of statistics. For example, exclusion of very early deaths or other situations in the analysis, maybe to mitigate the immortal time bias. Yeah, it would be good to look at this kind of mitigation statistical analysis pattern will be also a great project in the future, I think. Thank you so much. Yeah.
Excuse me. Yes, Florence LaCroix, Georgia State University. I love that you open with the need to establish more trust in the journals. As everyone knows, we got plenty of surveys saying on how public trust in the science community has dramatically dropped. So my question is regarding replication studies. As a physician, I work with medical errors, and one thing we found that has established trust of our patients with us is, we make mistakes and we will admit medical errors, tell them what we're going to do so it doesn't happen again. And they trust us. And even though I've done some serious mistake, they keep me as the anesthesiologist. And I would think that that form of publishing replication papers in our journals would really help establish trust, because we're going to make mistakes. All of us do. My question is, the last time I was here 3 years ago, I had 5 editors tell me that they, as a policy, they don't publish replication. 1, because their audience don't read it, and 3 were high impact, 2 were middle. 1, because of their audience aren't interested, 4, because they thought it would lower impact factor. This follow-up, we know this problem, as Dr. Goodman said. Any suggestions of you or Dr. Goodman on how can you incentivize journals, especially medical journal, which is where the lack of trust is really hitting, so they publish more replication papers? I think they're starting to do it as they become aware. But any thought? Because it's hard. I've been working on it for 3 years and
Yeah, so the replication, so you mean the replication study should be more published? Yeah. Yeah, so there are, I know that several journals published only replication studies. As you know, the Open Science already performed very cancer projects, and only 1/3 of the very influential journal was replicated. So reproducibility crisis has been discussed during the past 10 years. And I also saw in Nature also there is a section for the replicate, only accept the replication studies. And also eLife also published many replication studies. So many activities on these replication studies and pursued this kind of thing will be very improvement, although the process is not slow, not fast. Yeah, that's a real process, I think. Thank you.